All right. So I was a little bit cheeky and added a little bit extra to my title because I want to address community protection in the context of particulate pollution today. So I'll be taking you through some very basic information about what particulate pollution actually is, what its effects are, but also how we can protect people and the public from these kinds of exposures. All right, that's not clicking on. 1 second. There we go. Thank you again for the introduction, by the way. That was really nice of you to do that. And I've just got a little bit more information about myself here that you can read in your own time if you want. But I guess what I wanted to say is, I thought I'd give some background about why I am talking about particulate pollution. I am an environmental scientist. I have a PhD and a master's in volcanology, but really what my research is about the hazards and impacts of airborne particles, whether they are volcanic ash, industrial mineral dust, desert dust, combusted vegetation, urban pollution, etc. And as well as working on the hazards and impacts, I work on community protection. So in order to do that kind of research, I need to work across a vast range of disciplines. And so even though I come from the earth and environmental sciences background, I work across medicine, psychology, social sciences, the exposure sciences, and also law and ethics. My research was the first research that actually looked at the effectiveness of respiratory protection in volcanic settings, along with ISRP as partners. So I'll tell you a little bit more about that research as the talk goes on. So as I said, I'm going to start at quite a basic level about what particulate pollution is, and that's because I understand that the audience today will be some people who are consolidating their information and some people who are learning new parts about respiratory protection and the particles which impact it. So what is particulate pollution? We also can call this particulate matter or PM, and I'll use both of those terms in this talk. I guess it's a general term really for the solid particles, which in this case are suspended in the air, because when we talk about particulate pollution, we're usually talking about air pollution. Now, the word particle can refer to many, many different compositions. So there could be inorganic compounds, such as from agricultural emissions, so ammonium sulfate. We could be talking about sodium chloride from sea salt. We might be talking about various kinds of organic matter, even the skin that flakes off our bodies and is airborne in our houses. Or different types of particles which are the result of combustion, like soot and smoke, vehicle exhaust, etc. Then we have particles from soil dust, from volcanic eruptions, from quarrying and mining. There's tire and brake wear, which is a serious problem now in our cities. And of course, other kinds of biological materials like pollen and mold spores. There's also a second category of particulates, which we describe as secondary particles. And that means they actually don't start off as a particulate. And usually they are formed in the air by chemical reactions with gaseous pollutants. So for example, sulfur dioxide will react with the atmosphere to form sulfate aerosol. And actually aerosol is yet another term for tiny particulates. So the air that we breathe, both indoors and outdoors, always contains particles, but clearly we don't get ill from every particle we breathe, and also we don't describe every particle as pollution. So it really has to do with what the particle is made of and how much of it there is in the atmosphere, and whether it's then going to have a health impact. So some particles are large enough that you can see them with the naked eye, and some are so small that you can really only detect them analytically using microscopes, for example, or maybe aerosol monitors out in the environment. And this is really important when it comes to human health. The size of the particle is actually critical. So basically, particles that are sub 10 micrometers in diameter can get very deep into your lungs and possibly can even translocate into your bloodstream from your lungs and then travel around your body and deposit in other organs and cells and cause problems within those areas of the body. Now, what does a 10 micron particle look like? It's hard to envisage, so the diagram in this slide will help with that. And what you can see here is a drawing of a human hair and also some beach sand. And beach sand could be, you know, maybe 90 micrometers in diameter, and human hair is less than that. So if you took one of your hairs and chopped it in half, it would be roughly 50 to 70 micrometers in diameter. So what we're talking about here is particles which are even smaller than the width of a human hair, possibly 5 times smaller if we're talking about 10 micron particles, and possibly much, much smaller, 20 times smaller if we're talking about 2.5 micron particles. And these particles are given different terms, actually. We sometimes also call them PM10 or PM2.5, which effectively means particles sub 10 microns or sub 2.5 microns in diameter. Now, the smaller the particle, the deeper into the lung they can get, the more trouble they're likely to cause. And particles less than 1 micron or even 0.1 micron are the ones that might translocate around the body. But these are also the ones that are going to remain airborne in the atmosphere for longer than the heavier, denser particles. And these ones are going to be able to travel vast distances. And this is where we have the concept of transboundary pollution, where the pollution generated in one jurisdiction then moves into other areas, other countries, and therefore affects their particulate loads and therefore their compliance to regulations. And this can be a huge problem. Now, I'm not going to go into detail on this slide, but if you're interested to come back to it later, this shows where different sized particles deposit in the human respiratory system, and basically shows that the particles sub 0.1 micrometers in diameter are most likely to get into the deep lungs. So let's move on to where particulate pollution is focused around the world. And here we have some maps made via computer simulations showing where particles are basically found around the world. This comes from an academic paper by Weigel et al., published in 2018. And what you can see in these different diagrams is that they have split up the different types of particulate pollution. So SIA in the top left is secondary inorganic aerosols. Then you've got organic mass as OM, BC as black carbon, SS as sea salt, etc. And if you have a look, you can see that basically you find particulates everywhere, of course you do. But there are certain parts of the world where the pollution is focused. And those are particularly, especially when you look at dust in the top right, mineral dusts that are focused in the world's desert areas. For example, in Saharan Africa and the Gobi Desert, for example. But then we also see areas of the world which are badly affected because they are generators of anthropogenic pollution. So man-made pollution, such as through energy resources and different kinds of transport, etc. And so then this map now actually shows the sources of particulate pollution rather than the types of particles. And in the top left, you see all sources. And again, here we're looking at a simulated map of total PM2.5 mass. And you can see that again, we see particulate pollution is sourced from around the world, but that there are hotspots. And you can divide up the different sources of pollution into 6 primary anthropogenic categories. And you can see these listed as residential energy use, industry, power generation, agriculture, transport, and open fires. And these together make up 76% of the global PM2.5 exposure. Now, if we look at one or two of these in more detail, let's look at the top right image, residential energy use. You see that actually 21% of our exposures is sourced from residential energy use around the world, and that this is really particularly in places like India and China. So areas that are very populated and also are not highly developed yet. And the source of these kind of residential particulates is through biofuel use, diesel generators, and burning of household waste. And elimination of solid fuel stoves over a 20-year period could actually avoid 22.5 million premature deaths associated with these exposures. So there's a lot of work to do around the world in terms of these types of emissions reduction. Down in the bottom right, you can see other sources. Now, these really are the non-anthropogenic sources, and they make up almost a quarter of our exposures. And these really relate to mineral dust from desert areas, but also volcanic eruptions and other kinds of short-term events are also included within these categories. So we now understand that there are many different sources of particulate pollution around the world. And when we start thinking about the health effects, we need to actually understand the process that leads us from the source to the health effect itself. And it's not a simple process. So of course, the source itself has to be emitting the pollutant. And there can be well, there are many ways that you can actually try and reduce the emissions. But once the pollutant is emitted, it becomes part of the airborne load or the concentration of particulate. And this can be monitored environmentally using equipment around the world. But the concentration of particles in the air is not necessarily what you as a person are actually exposed to, because there are many different kinds of mitigating strategies that you can take to change your exposure. And so this might be, for example, wearing respiratory protection or staying indoors. And the route of exposure can also be different for different pollutants. And for particulate pollution, we're most interested in inhalation routes. Now, thinking through to the health effect itself, actually, it's not even the exposure that we need to know about, it's actually the dose in the body. And the reason why exposure and dose are different is because if you inhale dust, you don't necessarily retain it all in your body. You then will exhale a portion of it, for example. And so the dose is what your body actually retains and what it will react to in order to produce a health impact. It can be really, really hard to measure dose. And so often exposure or airborne concentrations are used as a proxy. And that's what our regulations tend to be focused on. So moving on to the health effects of particulate matter. We are now very sure through some large meta-studies, particularly the Revihat report produced by the World Health Organization in 2013, that particulate matter causes health effects after both short-term, meaning hours or days, or long-term, months to years of exposure. Unfortunately, there is no evidence of a safe level of exposure or a threshold below which no adverse effects occur. So this is why it becomes difficult to actually quantify and have a definition for airborne pollution, because there's not necessarily a level at which it becomes harmful. So as I explained previously, PM 2.5, or basically the smallest particles, are at higher risk of causing disease than the larger particles. And when I'm talking about diseases, we're mainly thinking about respiratory and cardiovascular diseases, such as asthma and heart disease. Although every day there are published studies showing how air pollution seems to affect different parts of the body. Every cell in the body has been found to have air pollution particles in it. And there are now studies about the impact of pollution on growth of babies in the womb, on brain development, and all kinds of different aspects. And of course, we need to worry about mortality or death, early mortality, particularly from air pollution. And again, these tend to be due to cardiovascular and respiratory diseases, including lung cancer. So we know that the more pollution there is in the air, the more likely people are to die of it. And in fact, it's known that an increase of 0.2 to 0.6% of PM10 per 10 micrograms meter cubed of material can actually, sorry, I think I said that wrong. Daily mortality is estimated to increase by 0.2 to 0.6% per increase of 10 microgram per meter cubed of PM10. So it doesn't take much increase in PM10 in our atmosphere for there to start to be seen increases in mortality. Susceptible groups are likely to be more impacted than healthy people. And by that, I mean people with health, pre-existing health problems such as lung or heart diseases, elderly people, but also children. And more evidence is becoming available to show that exposure of particulates affects children's lung development, their lung function, and their growth rate. So this is going to have a knock-on impact, because if you have a generation of children who have developed poorly, they're going to be less capable of adults at having a productive life, and this will then knock on into productivity of that country as a whole. So protecting children from air pollution, reducing their exposure so that they can have healthy lives, is critical. One point I just wanted to also make is that actually at a population level, there's not really actually enough evidence at the moment to say that one type of particulate pollution is more hazardous than another type. Now, that might sound strange, because we know, for example, that in industrial exposures, for example, crystalline silica dust is known to be highly hazardous compared to some other kinds of dust. But at a community public level, it's not yet clear. There's not enough evidence as to which types of particles are going to be the most harmful. I think that evidence will come, but for now, the World Health Organization just says that particulate matter as a whole can cause these different types of diseases. Well, so it becomes clear then that we need to stop people being exposed to particulate matter. The burden of air pollution around the world is significant. We need to manage air quality, we need exposure reduction strategies, and we need to reduce the health risks. And there are plenty of ways to do this. The primary way, of course, is to stop the emissions in the first place. And this can be at an industrial level, so changing different energy uses, for example, switching to cleaner forms of energy which aren't going to generate particulates in combustion. But we can also do things at a personal level, for example, walking our children to school rather than driving. We also need to be regulating to reduce these emissions and these airborne concentrations. And of course, then there has to be sign up to those regulations at a global level and compliance to those regulations. But you need to be able to monitor compliance, and that means that better air quality monitoring is required around the world. And there are still plenty of countries which have almost no air quality monitoring, and certainly not of a standard that's suitable for regulatory compliance. And finally, there is personal protection, so actually stopping ourselves from being exposed to the particulate pollution. And we're going to just look at that in a little bit more detail. There are several different models that are used to kind of intervene to stop people being exposed or to get ill or dying from different kinds of hazards. These are called public intervention models. And in the case of environmental models, there are 4 components. There's the public themselves and the disease that they will get and the fact that they will die. And then there's what's actually causing this problem, which is, in this case, the environment. So the clinical intervention model that you can see at the top here basically is the medical model. So when doctors will actually come in and stop you dying by halting a disease in its tracks, by curing the disease or trying to reduce its level so that you don't die. What we're really talking about when we're talking about air pollution is, on a large global scale, is the public health intervention model, which is where we actually try and stop the environment or the air pollution from causing disease. And the way we do that, as I just explained, is through process controls, emissions reduction, and exposure reduction. However, people are not necessarily willing to wait for that to happen and for their environment to be cleaned up by someone else. People want to take matters into their own hands and protect themselves. And this is called the environmental stewardship model, where basically you stop the public from actually being exposed to the environment in the first place. And if you can do that, then you stop the disease from forming and therefore the deaths. This requires social and behavioral change. Now, we started to see this not just through public health interventions and through government interventions, but through personal decisions, starting in China in 2003, when the SARS crisis meant that respiratory protection was worn by the public in a large scale for the first time. And following that crisis, people continued to wear respiratory protection to stop themselves being exposed to air pollution. And now, of course, with the global pandemic with COVID-19, we are starting to see the normalization of respiratory protection around the world. And it will be interesting to see whether this means that people will start to now use respiratory protection more to protect themselves from air pollution. So this is about personal behavior change, but it's also about risk communication. So it's about governments trying to change behavior by communicating the risk to the public. So looking a bit more closely at the public use of respiratory protection in crises, in PM crises. As mentioned, some Asian countries have already been wearing respiratory protection in a non-occupational setting for quite a while now. Like I said, China started with infection control and moved on to air pollution. In Japan also started with infection control, but I don't think so much people wear masks there still today for air pollution problems. It's more to do with fashion trend and also some social pressures. However, in Indonesia, Vietnam, and Thailand, which are 3 countries that I know about, people are now commonly wearing respiratory protection to protect themselves from air pollution. And this is particularly people who are traveling on public transport or personal transport, such as scooters. And you can see in the top right image here, people wearing kind of cloth masks. This is very, very common in Indonesia, Vietnam, and Thailand to protect themselves from pollution. And so mainly these countries are wearing cloth masks, or which are also called fashion masks or scooter masks there, and also surgical masks. But there is growing concern that people who are doing this are not understanding the efficacy of these masks. They will take more risks because they think they are protected, and therefore they will have a false sense of security. And I've put a link to a paper there if you're interested in looking at that. Now, there are other kinds of reasons why people, the public, wear particulate pollution masks, particularly in non-anthropogenic particulate crises. So, for example, natural crises such as volcanic eruptions and wildfires. Now, in my experience, until recently, non-governmental organizations and governmental organizations commonly distributed surgical or other cheap masks in these crises in lower middle income countries. This was because they already had these masks stockpiled for pandemic reasons. And it's going to be interesting to see whether they can afford to give these out in particulate crises during COVID. Also, non-governmental organizations, governmental organizations, and also mask manufacturers have distributed or donated N95 or FFP2 masks, mainly in high-income countries. So on the bottom right, there's a photo here of people being given N95 masks in Hawaii in the 2018 volcanic crisis there. In my experience, until about 5 or so years ago, this was the norm, was that people in North America and in Iceland and places like that would get the best masks in volcanic eruptions, and people in Indonesia would be given substandard masks. This inequality, I believe, is now slowly changing, and actually this is partly due to a project called Health Interventions in Volcanic Eruptions, which I led and which ISRP were partners on. So this was the first research to try to quantify the effectiveness of different kinds of respiratory protection worn by communities across the world when there is a volcanic eruption. And I haven't got time, unfortunately, to tell you about the project in detail, but I'm just going to show you some final results. This rather messy graph shows filtration efficiency of a range of different materials used by communities around the world in volcanic eruptions. So in the lab, we measured the filtration efficiency against PM2.5 particles in 2 types of volcanic ash, and also aloxite, which was an analog dust that we used when we were next going to expose our volunteers. I'll talk about that in a minute. So what you can see in this diagram is that in the top right, I hope you can see my mouse, in the top left, apologies, you can see N95 masks and N99 masks, which not surprisingly performed extremely well with almost 100% filtration efficiency. Surgical masks, and actually some of the cheap masks that are handed out by agencies in eruptions actually also performed very well. This is actually a mask designed to capture PM 2.5 particles. But then you can see that as you move into the fashion masks and the scooter masks and the nuisance dust masks, the efficacy or the filtration efficiency drops off substantially. And here, when you reach the single layered materials, so cloth materials, we see that, in fact, sometimes the particles passed straight through the masks. So we also tested what it would be like if we took a bandana and folded it several times, and whether that would include the filtration efficiency. So here is 1 time, 2 times, and 3 times. So it did work, it did improve it a little bit, but still nowhere near as good as wearing a surgical mask. Or rather, I should say the filtration efficiency of a surgical mask. Also, many agencies around the world actually recommend people wet their masks, and it wasn't clear to us that this had any improved filtration effect. So we tested it, and here is a bandana wetted and folded 3 times compared to the dry one 3 times, and you can see it actually performed worst. The same was for surgical masks. This is the wet surgical mask here and the dry surgical mask up here. So wetting does not help. So we then took the best performing masks and we asked volunteers to wear them in the laboratory, and we tested here total inward leakage. So this takes into account the fit of the mask as well as its filtration. So you see the same filtration results as you just saw on the previous slide, and here we have the leakage. So the least leakage, which is what you want, was for the N95 style mask. If you have a regular surgical mask, we had around 35% total inward leakage. So not terrible, but certainly not as good as the PM10 mask. But the PM10 mask was not comfortable to wear, and the surgical mask was much more comfortable to wear. So compliance is likely to be higher. Here you see this cheaps mask that performed very well, which is actually a highly efficient mask, but when you wear it, it flops around your face and has poor leakage. We also had an enhanced surgical mask from Japan that again is designed to be worn for air pollution exposures and has some added features to make it fit better, cheek and chin flaps, and indeed it improved its efficiency a little bit. We also tested what would happen if you wore a regular surgical mask and a piece of cloth on top, and whether that would improve the fit and therefore the leakage. And so here with a mask and a bandage on top, it improved the leakage by about 10%. But of course, this was not particularly comfortable. But this was all done in laboratory conditions. We also conducted some wearability surveys in Indonesia. You can see on the left here, a woman wearing these same masks. You can see this mask here and just how enormous it is on her face and how poorly it protects her, despite having excellent filtration efficiency. These field trials basically found the same kind of rankings of comfort as we saw in the laboratory. So surgical masks being the most comfortable, and N95 masks or wearing a cloth on top of a mask being least comfortable. So what we found in our research was that there seemed to be this kind of ethical issue that agencies were going to face when deciding what kind of face mask to distribute to communities affected by wildfires or volcanic eruptions, for example. They basically have 2 choices. On the left is the precautionary principle. This is the principle that some protection is better than no protection, and it's better to hand out whatever masks you've got in supplies, such as surgical masks. On the other hand, you have the principle of effectiveness, which is that only effective protection should be offered. And in a way, this is the first principle of humanitarian aid, that you should not be harming the people that you're aiming to help. You should only be giving effective interventions. And so we did quite a lot of work around this, and trying to explain to agencies the findings of our studies in the laboratory, etc. And as a result of this, a lot of agencies have tried to switch now to offering better forms of protection. And the reason they've done that is because they realize that there are ways that they might be able to afford that kind of mask, for example, by crowdfunding or by asking manufacturers for donations. And this happened in the Agung eruption in Indonesia 2 years ago. So What we also found, though, of course, is that there are going to be some agencies, particularly governmental agencies in low and middle income countries, which cannot afford to purchase these masks and don't have the mandate to either. And in that case, we are trying to get across the message that they must tell the people that they're providing the intervention to that this intervention may not offer them a very good level of protection, and therefore they may have to take some other actions in order to reduce their exposure. And the way to do this is really through public communication. And so we spent a lot of time developing public information products. So that's the following leaflets, posters and booklets that you can see here, but also a range of videos so that agencies could actually provide this information rapidly in an eruption. And these are endorsed by the World Health Organization. And we actually involved local community members and local agencies in developing these products so that we could make sure that they were actually useful and were going to be used. The other thing that we did was make sure that people actually understood how to use these masks if they were going to be given them. And so with ISRP, we conducted a train the trainer workshop in Indonesia. We trained stakeholder representatives in how to fit face masks, and the reps then trained each other, and so that they in turn were ready to then go out and train many more people. And now more than 1,000 people have been trained in this region of Indonesia near Merapi volcano. And we'd like to be able to do a lot more of this in the future. So to conclude, I'm sure that particulate matter crises such as wildfires will worsen with climate change. We're seeing that already, it's very clear. However, over time, anthropogenic PM sources will lessen with implementation of effective emissions reduction strategies in the energy production sectors and transport. And hopefully we'll start to see this in the future in currently developing countries. But in the meantime, people won't put up with poor air quality. They are taking matters into their own hands. They want personal protection. And COVID-19 has opened the world's eyes to respiratory protection. It has become an acceptable social norm, and we can expect to see that people are going to start to wear the protection they've got used to wearing for COVID-19 for other purposes. But the problem is that we still have a lot of missing evidence about the efficacy of face masks for community use, particularly for children. And it's becoming more common that children are wearing face masks, not just for COVID-19. So I have a new project called Face Up, Factors Affecting Childhood Exposures to Urban Particulates, which again, ISRP is a partner on, where we will be testing the effectiveness of face masks for children. But I also think that better public information is required to inform the world of the efficacy of different types of respiratory protection for different purposes and the suitability of that protection for different susceptible groups. And I think this is why ISRP is so important. I think there's so much work that we can do together to try and develop these resources and try and raise awareness around the world. Thanks a lot.
Thank you, Claire, for a fantastic presentation, very informative. There are just a few questions. I'm just going to start in the order that we received. So we have an anonymous question in the chat box. Is there an actual formal definition for respiratory protection?
Well, that's a really good question. And I'm probably least qualified to answer this on the call, I would think, because there's so many more people on the call who are experts in respiratory protection. My understanding is that in industry, the term respiratory protection or respiratory protective equipment is very specific to, masks that have been developed for use in industry and certified to certain standards. With COVID-19, all kinds of different terminology has been used with face masks and face coverings. I think there's a lot of confusion out there about which terminology to use. But as respiratory protection, such as disposable N95 masks, are being used more by the public, I think these terms are kind of conflating and are being used more commonly.
Thank you for that. And then we have, I'm going to combine, in the interest of time, I'm going to combine the two. And it's around your testing of the various masks, respirators, materials. and it's how was the total inward leakage measured? And Menno's follow-on question from Karen's question was the same for the field measurement. How was that done?
Okay, so first of all, the field measurement was not a measurement of total inward leakage. It was just a social survey of wearability. So in that circumstance, we had people actually walking around a school playground when ash was actually falling, and wearing respiratory protection, then filling in surveys. And the article is linked to in my talk, and you'll have a copy of the talk. In terms of the total inward leakage test in the laboratory, this was done at the Institute of Occupational Medicine, Edinburgh, and we had a chamber set up which had surrogate dust, aloxide, being lofted into that chamber, and then volunteers went in wearing protection. They were wearing goggles and everything else as well, but they had face masks on which had basically a hole drilled into the front, so that we could measure the particulate inside the mask. And then also each volunteer was wearing a small TSI side pack, so a small aerosol monitor on their waist, which had a tube in the breathing zone, so that we could compare what was the dust outside their mask to what was inside, and then you compare the difference inside and outside in terms of concentration of particles.
Thank you. And then just a very final question in the interest of time. How do you approach the fit testing of underage participants in your new project?
Yeah, well, we haven't started the project yet. It's based in Indonesia and Nepal, and we can't go there at the moment, and our partners in the country aren't allowed to work. But what is going to happen is that we'll be using fit testing equipment, Coulter particle counter, and basically it all goes through ethical approval. The children are not put in any kind of dangerous situation. They are in their normal environment, which sadly is quite polluted, which is why we've chosen those locations, so outdoors, and we'll be then using a normal fit testing procedure to test how well the mask fits their faces.
In the interest of time, I know James has asked another question. If you're happy, Claire, what we will do is further questions received, we will post them to you. And if you can answer them, and then we will post them on the website as answers, if that's okay with you.
Yes, certainly.
Brilliant. So thank you very much for that fantastic talk.